aspects of our health system. They're here to talk a little bit about it and hopefully to answer some burning questions that you all might have. I'll start with Ann. Ann Louderyoung is a registered and licensed dietitian. She's been working as a nutritionist for 29 years and is a certified diabetes educator for 11 years. Ann is an outpatient dietitian at President St. Mary's Hospital, where she spends her time helping people overcome the barriers of diabetes and other diseases through better nutritional choices and self-management techniques. Welcome, Ann. You can clap. Awesome, thank you. Daphne Mitchell over there has been a nurse for more than 40 years. For the past 17 years, she served as Director of Surgical Services for hospitals in metropolitan Chicago. Daphne is a longtime activist who has served the Ottawa community and the state of Illinois in a wide range of capacities, from Cub Scout Den Mother to board member for the Illinois River Coordinating Council to holding elected office as past Commissioner of Finance for the City of Ottawa. Welcome, Daphne. This is Neil Mohammed. He's a healthcare consultant and a Democratic candidate to represent Illinois' 16th Congressional District. Yay. He has spent more than 7 years working with hospitals and healthcare systems all across the country. Neil helps hospitals cope with the skyrocketing costs of prescription drugs and private insurers who don't want to pay for critically needed patient care. Welcome, Neil. And Julie Hogue has been working within the nursing program at Illinois Valley Community College since 2007. She began there as a nursing instructor, and now she's the Director of Nursing Programs and Health Professions. She brings a unique twofold perspective to this forum. Beyond her career in professional education, Julie was diagnosed with breast cancer in 2007. She received treatment and is now cancer-free. Way to go. Now Julie is navigating the healthcare system for her father, who's experiencing some health issues of his own. Welcome, Julie. Yeah. I want to thank everybody for coming, these wonderful panelists, all the people who helped us do this. Please make sure you grab a drink from the bar because this venue was donated to us for free. So there have been a lot of people who made this happen. And I just have so much appreciation for everyone. I'm going to introduce our moderator, the wonderful Mary Gajiva, who made these fabulous baskets, which are not raffled off. So that's it for me. Mary, it's all you.
Thank you, Jan, and thank you all for coming tonight. This event grew out of our local Ottawa Indivisible organization when we began looking at healthcare issues. We immediately recognized that none of us were experts. We wanted to know more, and we wanted to share that with the community. Who knew healthcare was so complicated? And so we would like to get some background from different perspectives in the healthcare industry about where we've been, where we are, and what the future may hold. And the format will be very simple. We're simply going to go down and give each of them a chance to talk for as long as they want, as long as it doesn't exceed 8 minutes. on each of those topics, beginning with where we have been in the past with healthcare. And if you would prefer to stand to speak, however you are most comfortable. At the end of those 3 sessions, we will open up the floor for questions. That's it. Thank you very much. And since you are first. The first topic is, how did we get here?
Well, good evening, everyone, and thanks for having me. As panelists, we received the questions, and first thing, where have we been? And I said to myself, well, I'll go to the library, do a little research, see what's been going on in healthcare and stuff. And the things that I read and background and that, it was interesting. And the thing that sticks out in my mind of kind of where things have gone, and probably healthcare insurance and paying for that didn't happen until the late 50s, early 60s, and that when, companies began to help, share the cost of insurance for their employees. And some of them paid all the insurance, some of which, 50-50. The government then decided to give those employers tax breaks for providing insurance to their employees. So we've always had, that incentive. But I think what happened? Where did things get off the track? I think as our economy changed and businesses decided that, well, we could save money if we, cut back on these nice health care plans we were offering our employees. Why do we need to offer them $1,000 worth of benefits? Let's only buy a benefit package that's maybe $750, and then we can keep that other $250. And I think it became a whole thing about them generating more profits. And people, are always like, oh, but my company pays for my insurance. And I read the thing too. Yes, your company pays their portion, and a lot of us pay our own portion of it, but still, that is, considered your big lump sum compensation. That, I get these statements saying that, I know what my take-home pay is, and what my net income when I'm doing my taxes, but then there's this other couple $1,000s that, are these benefits that, and I'm like, well, that's all well and good, but I think over time, that number kind of keeps dwindling, even though, our employees still like, well, we're still kicking in this, and it's like, well, yeah, because, unemployment and Social Security and Medicare, that's kind of mandated. You have to pay that, but, and I always feel like, don't do me such a big favor. But even with that being said, and then the jobs that were out there that people, worked at and made a good living wage in that, those jobs have, it's shifted. Things have gone overseas, technology has changed, so now, we've moved to more of a service industry and those jobs. And, I think, these new companies and, even the smarter older companies like, less health insurance. It's not, they're more interested in their own profit than maybe the health of their own employees. So I just, there's a lot of things out there. The other thing that when I was reading it, it made me just think for a second, we don't shop our healthcare services the way we shop for anything else, like a new car or a new sweater and that. We don't say, hey, Macy's has it for this, I can get it from Walmart for that, what's my quality? And when we need emergency care, you can't really be like, well, I don't know, I'll go to this emergency room or that emergency room. But even that's, those are big expensive things, but our day-to-day health care, no one thinks twice about it. But and we'll get into as I become even a more savvy shopper based on what my insurance pays. If I stay local, I pay more. If I drive a little bit further, I get a better benefit. So I've become a little more savvy customer.
Thank you.
Well, you're in a good crowd for this discussion when your answer on long-term economic trends in the employment market actually gets snagged right ahead of you in your answer. I'll just say first, thanks to Jan and the rest of the Ottawa Indivisible group for putting this together and for you all for being here tonight, because I know there was a little bit of a scheduling issue with a certain sporting event up the street, so I'm glad you were here. I wanted to say two ways of answering the question of how did we get here. One, I want to talk a little bit about how I got into healthcare in the first place and why I'm so interested in this issue and why coming to these kinds of forums and talking about this issue really is my favorite part of this new adventure I'm on with the congressional race. So when she was in her early 20s, my mom was diagnosed with something called Crohn's disease. Which is an autoimmune disorder, and that's just a fancy 10-cent word that means your immune system actually turns in against itself and it starts attacking healthy cells. And it's something that treatments have gotten better for recently, but at the time, there wasn't much for it. And so what you would do is take steroids to sort of manage through the symptoms, manage through the inflammation, and every so often you'd get to the end of that, and your body couldn't take the steroids anymore. So you'd have to have a major surgery, and you'd have to have a good chunk of your GI tract taken out. You repeat that a couple of times over the course of your life. So I was in 7th grade, and it was actually, of all things, the week or so that I had discovered I had made the travel soccer team in DeKalb, where I grew up. which came with it the privilege of driving to the big city, which was Rockford, every week to play. But I got that news while my mom was in Chicago at the University of Chicago's hospital having one of these surgeries. And that was a really difficult experience, as you probably expect. That's a lot to have on your mind at age 12, thinking through these things like, is she going to make it? And if she doesn't, are we going to have to live with Dad by ourselves? How on earth is that going to work? He doesn't know what he's doing, that he'd be in over his head. Your mind just kind of goes a mile a minute. And I started getting in trouble at school, I started getting in fights, all these things that looking back, kind of makes sense. It's all straightforward. But among all of that, the one question I never had to grapple with, the one question that I never had to worry about was, will she be able to go to the doctor at all? She was a state employee. Obviously, that's a hot, sensitive topic these days. But she was a state employee, and she had good insurance. And so at least from that perspective, that wasn't ever an issue. Everything else, terrifying, absolutely terrifying. But the prospect of actually going to the doctor itself was never an issue. And obviously, that's not the case for millions of Americans. And that's wrong, and that's staggering, it's gross, it's morally reprehensible, and it's something we've got to change. And I think a lot of folks in this room probably have a story like that. So thanks again for coming, thanks again for being part of this process, and thanks again for just your interest in this really important issue. So to the part of my answer that Ann stole from me. So the other way to answer the question of how did we get here really is, why do we have the system we do? And Ann was absolutely right. It starts a long time ago. If I go all the way back and ask a really simple question you may not have considered previously. Why does your health insurance have anything at all to do with where you work? We all probably know that we spend way more than other countries do. We have worse outcomes. We have worse child mortality. We have worse maternal mortality. We have lower life expectancy. All of these horrible things. That's in consequence of what I'm about to say. We have employer-sponsored health insurance and nobody else does. Nada. The reason we have employer-provided health insurance, I probably shouldn't make this joke, but I will, it has a lot to do with, unfortunately, what's driving some other parts of our national politics these days, which was Nazi Germany. During World War II, we had this explosion of women entering the workforce, massive government spending, 90% of government budget between 1942 and 1945 was devoted to the military. People were worried about inflation, government spending, blah, 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 blah. So we had wage controls. People said, we can't have the price of labor going up even though there's fewer people to work and women are coming to the workforce. So we're going to cap wages and freeze them. Well, the economics still are what they are at that point. It's still hard to find people to fill these jobs. So what happens, sort of wink, wink, nudge, nudge relationship at first between big employers and the IRS. They say, okay, we're not going to let you give people higher wages. We will let you give them health insurance, and we won't tax it. And as Ann said, over time, that just got sort of written into our rules, and now we don't even think about it. As many questions as people have about healthcare right now, I can guarantee you very few people, I shouldn't say this, but I think very few people have stopped to think about why employer-based insurance even exists. And it has a lot of negative consequences. I'll just focus on one before I wrap up. Anytime you change a job, your health insurance may change. Your doctor may no longer be in network, different prices for your prescription drugs. So people have actually documented this is a serious obstacle to starting your own business. It's a serious obstacle to changing jobs. People get in a situation called job lock, where you don't want to change your doctor, so you stay at a job that may not pay you very well, may not be the right job for you. People stay in marriages because they can't afford to lose their benefits. You may know some people. I won't ask you this question, but some of you may be in that group as well. The idea that your healthcare has anything to do with your job is endemic, it's fundamental, and it's completely wrong. It drives costs, it reduces outcomes, and it has all these other effects on the economy that are terrible as well. That's, in my sense, the original sin in some ways of American healthcare, is this bond between where you work and what doctor you go to, and that's something that we need to break.
Sit or stand if you, whatever is comfortable.
Sometimes it just takes me a couple times to get it there. Okay.
Stuck in the middle.
I want to thank you too for asking me to be here. This is not one of my normal kind of activities, so I'm a rookie at this. So I ask for your patience in that regard. And I'm just going to share with you what I thought about as I looked at these questions and went out and tried to find some answers. Some of them were already kind of in my head. And I'm going to also build on what was said earlier. And I'm going to start with that. And I want to go back to World War II. At the end of World War II, 1945, there was a huge baby boom. 3.4 million babies were born after the end of the war. We called them baby boomers. And I count myself as one of them. I'm one of the last of them. However, 2017 minus 1945 equals 72. So the bulk of those people are on Medicare, and in this, of that 3.4 million, that huge burst, it was the first that had been seen at that time. So we can go back and see where the numbers increase. And then there's Medicare and Medicaid. 1965. Lyndon Johnson signed it into law. Either program, either the Medicare or Medicaid, has evolved into a program that it was never originally meant to be for. It had a different intent totally years ago when it was developed, but we need it now to do things that, because of the advances in healthcare, we need Medicare and Medicaid to keep up. And we also need it to keep up with the numbers, because those numbers are entering into Medicare age. And the question is, are we doing it, meeting the needs, and are we doing it well? And I would say we're probably, it's not broke, as in no dollars yet, but as far as doing it well, as far as providing health care well to the community, I not so much. I think we can do much better. Back, you've been in there 40 years?
Over 40 years.
40? I'm 30, oh geez. Let's just say 36. And so when I first went to work, 36 years ago, it was not uncommon to have a patient admitted to the hospital for 30 days for dizziness. And they never asked, Medicare never asked questions. So it was very unregulated 36 years ago and more. And we're kind of paying for that now. If we had had regulations in place before and limited stays, but then we didn't. And so they could see that we were running through money rather rapidly. So then they began to introduce the DRGs and all of the restrictions and all of the rules necessary to try to control healthcare costs. Did it work? No. Healthcare costs continue to rise. No. So, and of course, through this whole course, you have to acknowledge the Affordable Care Act because that's part of our history and part of our road to where we are right now. So, and the future of that, well, that's a different question.
Yeah. Changing by the hour.
I found through my research, according to Blue Cross Blue Shield, price of medical care is the single biggest factor behind U.S. healthcare costs, accounting for 90% of spending, healthcare costs. So it's a huge problem. Okay, that's me.
Thank you.
Well, I'm going to give you a little history, a really quick history lesson, which I think says it all on where did it begin, where, what started this. Back in 1945, actually, it'll be in November, I think November 19th, 1945, so 72 years ago, a mere 7 months into a presidency he inherited from Franklin D. Roosevelt, Harry S. Truman, proposed a universal national health insurance program. My. So I'm probably going to be a little bit negative tonight because I've lived 40 years of this. We debated a national health care in Ottawa High School debate team in the 60s. I found my index cards not long ago when John and I were cleaning out the garage. And both sides of the question, should we have it or shouldn't we? We're still debating this. It's about money, folks. It's about the insurance companies. It's about the different organizations, the device manufacturers, the people who make the products, who have literally ruled us. And I can give you, and I will give you examples of how we have tiered care in this country. Truman proposed a universal national health insurance program. In his remarks to Congress, he declared, "Millions of our citizens do not now have a full measure of opportunity to achieve and enjoy good health. Millions do not now have protection or security against the economic effects of sickness. The time has arrived for action to help them attain that opportunity and that protection." So back to what the other members on this council have said, where have we come? We're right back to what he proposed. And unfortunately, Congress at the time, and there were 5 different points that he had, and they were okay with a couple of them. And then when it got down to insurance companies and people choosing their own, oh no, we don't want, quote, socialized medicine. Well, he didn't get it passed here, so more history for you all to look into is he went to Germany, and it was post-war, and they wanted to get Germany and the other European countries built back up, and the basic tenets of his program were enacted in Germany. So the healthcare plan Germany has now, the national healthcare plan they have in other European countries, was based on Truman's plan back in 1945. So here we are in 2017, still arguing this, fighting this, seeing tiered care, people without care, some people with care. I work in a hospital that is called a safety net hospital. It's Mount Sinai in Chicago. It's in the news all the time for gunshot wounds and accidents and many, many things. Today, I spent 2 hours of my time with our insurance people to try and get an implant from a lady who has breast cancer, and 2 of our really fine surgeons, one from the University of Illinois. The one surgeon does the mastectomy, and the plastic surgeon comes in and does the reconstructive work in breast implants. And there is a new method now where, and I'm going to be graphic, but women in the audience will understand, in order to do the procedure now, the way it's done now, the muscles after the mastectomy have to be stripped off of the chest and the implants put under the muscles. With the implant that is $9,000 with the one company, $8,000 with another, there is a big rectangle of tissue that's put on the woman's chest where the breast has been taken off, and the implants can be fixed to the this implant? Well, the lady that's going to have this procedure has Medicaid, and Medicaid pays in a lump sum payment. That you can't have a carve out where if you have your own insurance through your employer or any policy that you have, Blue Cross Blue Shield, the PPO, there are carve outs. So every hospital, including the hospital in Ottawa, all our communities, have to make individual contracts with insurance companies for how much they are going to pay for surgeries, for MRIs, for CAT scans. Every single one. We have 12 different Medicaid providers that we used to have one. Now Medicaid, they're different HMOs through the Affordable Care Act, which was really the Romney plan, and that's the best we could do to get something passed, which was really a Republican plan that Mitt Romney had put in Massachusetts. That's the best we could do. And with those types of things that are going on, the healthcare providers are having to do individual agreements with each company, whether it's an HMO or an insurance company. This is what we're facing, and it shouldn't be. We are 37th in the world, 37th in the, quote, Western democracies in our healthcare, our outcomes, our cost, which is when we're the most costly of anywhere on earth. So how did this start? It started a long time ago. It did start, let's say, in our, quote, modern age with Harry Truman, who really tried, and Lyndon Johnson did the next best thing, which was getting the Medicare, Medicaid. There was a day, I'm sure, when you and I were first starting in our career, when Medicare wasn't the best. Hospitals were like, oh, Medicare doesn't pay that well. Now everybody is just, clamoring for Medicare because it's the best payer outside of the really, really high-end Blue Cross Blue Shield policies. So it's very interesting because Medicare does pay well, and whether it's a Medicare for all or some type of program where we don't have this dichotomy, I don't know what's going to happen. The insurance company is going to call me back to let me know what's going to happen if there is any way to carve out so this lady can have this procedure. Otherwise, it's going to be done the way, because there's terminology in the healthcare field where I asked the doctor, is this now standard of care? And he said it is not standard of care yet. It is commonly done for breast surgeries, for breast cancer surgeries, commonly done, not to the standard yet. And so that often is how the insurance companies base on whether they're going to pay for it or not. So if it costs us $8,000 for that implant, and whatever our costs are to do the surgery, it may be a $20,000 cost to us for just what we're buying, and the insurance company pays, maybe they'll pay $5,000, maybe they'll pay $7,000. The costs are totally absorbed by the institution. So many are not going to survive. We know that we're one of the few safety net hospitals that take patients that don't pay. We did $27 million in free care last year. In one hospital, $27 million. So you multiply that by institution after institution, because there are people who cannot pay. They're undocumented people. We take everybody, and everyone should be taken. And then what do you do? So we have a long way to go, and we really need to fight it, folks, because our children, I don't know what will be left for them. Yes, Medicare and Social Security are not suffering. There's been a lot of money paid in, so don't buy the argument that they're going broke, because this is all about, it's about money, and it's about control, and we need to offer the same care. I cannot stand thinking about tiered care, that if you have a really good policy, you're going to get it all paid for, and if you have something else or nothing, you are not going to get the procedure that you need. And that was just one example.
Thank you. Thank you very much. I think you did a good job in getting us started on today's challenges, which is the next part of this. Would you like to go in the same order again? No, we'll skip over one. Neil, you get to go first this time.
Mix it up a little bit.
Mix it up.
So I think there's probably 2 or 3 main categories of challenges. One is, equity and access, and Daphne talked a lot about that. She's absolutely right, of course. One is cost. So, and if we think about cost, and this is certainly on everyone's mind, I think it needs to be underlined just how much cost in our system is driven by exactly the kinds of practices that Daphne just described. It's not the cost of end care to the patient so much as it is every other step along the way. So think about, we'll go back to Joel touched on employer-based healthcare. Let's think about that for a second. Every 2 weeks, your employer takes some amount of money that you don't see. You see your contribution, you don't always see their contribution. They see some chunk of money, you don't see some chunk of money that they pay on your behalf to the insurer with whom they've contracted. And that adds up. And you've probably seen this working in the industry as you do, as hospitals consolidate, they gobble everything up. I was working at the University of North Carolina's health system a couple of years ago. I worked in Chapel Hill for their academic medical center. There were 8 hospitals in their system then. By the time I was done working with them, there were 11. A couple of weeks ago, they merged with another system called Coastal Carolina. Now they're 30-something, probably. The reason they do that is because they need to have a bigger stick to go after the insurers to make them pay for the kinds of procedures that Daphne was describing. Meanwhile, the insurers see that coming, and so they consolidate, which is why there was a merger that was called off at the last second because it turned out there was a lot of bribery involved, political bribery. Our nation's 2nd largest insurer tried to buy our nation's 3rd largest insurer. And they do that so they can have an even bigger stick to come back to the hospital systems of the world and say, no, we're going to pay less, not more. That happens year after year after year after year after year. And what I'm getting to with the employer thing is really important because as costs creep up, it was the sort of bidding war, this tug of war between insurers and providers, the money keeps coming out of your paycheck. At the end of the day, the insurance company can always quote a higher rate to your employer for your insurance plan. And because in most states, 2 or 3 companies dominate the market for employer-based insurance, there's no real competition. Anytime they need extra money to pay, to get to the contract with the Mount Sinai's of the world, well, they just take a little bit more out of your paycheck. So we pay on average $9,000 or so a head, man, woman, and child for everything related to healthcare in this country. Every other country pays about $6,000, worst case scenario. $3,000 for every person. I think a household on average has 4 people in it. The average household in the 16th Congressional District of Illinois makes about $47,000. 3,000 times 4 is 12,000. That's a 25% tax on every family in this district. And it's just going to the kind of nonsense that we're all describing. That's a really serious challenge. And while I think we all understand that healthcare is too expensive, we see the hospital bills come back. You see the $400 Band-Aid, which is not unfortunately an urban legend. I'm sure we'll get into that later in this discussion. You hear those stories, but I think we don't always see what's under the waterline, so to speak. We don't realize how much we're all paying already, regardless of whether we even go to the hospital, regardless of whether or not we even go to the doctor. And that's massive. And if we think about the reasons that nobody in this country, very few people in this country have gotten a pay raise in 30 years, that's where the money went. So there's an equity issue, there's an economic issue, and the other thing I'll touch on real briefly is an investment issue. If there's one other thing I want you to take away from this discussion, it's this. Private insurers, we talk about innovation, private market, and so on, so on, so on. Private insurers don't innovate anything. They create nothing of value. The only innovations that have been made in terms of how we pay for insurance, how insurance works, or how we pay for healthcare, how insurance works, have been made by the government. The VA system was the first system of hospitals anywhere in the country to adopt something called an electronic medical record, which substantially drives down pharmacy error rates, substantially increases care. The next doctor sees what already happened. You don't have paper charts floating around, as these folks can tell you. That was done by the VA. Medicare, and this is also a double-edged sword, and I'm sure we'll hear in a bit, Medicare has led the way in trying to tie the amount they pay for care on your behalf to actual patient outcomes. Private insurers weren't doing that. And the reason why is really simple. Medicare, Medicaid, the VA system, they all have incentives to invest over the many years in what happens to you. They want you to be healthy because they know, and particularly as life expectancies go up, they know that they're going to be on the hook for your care for 20, 25, 30, 35 years. So there's a lot behind them trying to figure out how to reduce the cost of care, how to reduce something called variance in care, how to reduce error rates, how to make sure you're taking your meds, how to make sure that if you've got a long-term chronic illness, diabetes, something like that, making sure that you're staying up on your meds, on your regimen, because they know you're going to be there for 30 years. The private insurance market doesn't care. The average employer changes insurance companies. They're buying insurance on your behalf every 3 years. So there's never enough skin in the game for the insurers to pay ahead to make any of these things possible. So I think there's an equity issue, there's a cost issue, that cost and how it's borne by working families all across this district. And then there's this investment issue. Are we even doing a good job at fulfilling the functions that the insurance companies are supposed to fill?
I'm going to stay right here. Okay. So, challenges. So again, from a different viewpoint, from a person who I've spent the last 10 years trying to create nurses who care and who don't make mistakes, because that's the kind of people we want taking care of us, correct? I always tell the students that seem to be stuck on the fact that our job is to help them to pass the NCLEX exam. And that might be one part of it, but the other part is that we need a qualified, competent nurse who can critically think and yet be compassionate and provide care to the people that they're caring for. So it's kind of a two-pronged issue. In that, I like to think that we're successful. Overall, in this country, we still need to decrease the number of medical, not just medication, but medical errors that are committed every day in healthcare. I read in an article that there are 500 medical errors performed every day in the United States. But when you think about the number of procedures that are done and medications that are passed just in one hospital, just if we took St. Elizabeth's, there's way more than 500 that are done in 24 hours. So if you look at it that way, it makes it look a little more manageable. But the nurse in me, the perfectionist in me, wants that 500 to be zero for everybody. So I had quality of care, and I think I've pretty much talked about that. One thing that drives costs up is the providers who have to carry liability insurance because their premiums are going up. And their premiums are going up because doctors and nurse practitioners and physician's assistants are being sued. So that's another angle or another facet that I think needs to be addressed. If we could cap the amount that's paid out by juries, and we could cap, and have a resulting lowering of the premiums for liability insurance, then I would hope that that savings would then be passed on to the consumer. I'm probably dreaming. But we face, and I can tell you this, we face a lack of caregivers. We have more and more people entering the market who need care, and we have less and less people to do that. I have currently, the last 2 years, less and less people entering the profession, entering the school of nursing. And that's not just me. I just met with deans and directors of all of the associate degree colleges in Illinois, and everyone is seeing a decline in enrollment. And then we're also seeing a decline, probably an increase, in the number of students who are not successful. So they do come, but they're not prepared for the level of study that it requires to be successful in a very heavy course. Nursing courses, they're just not capable of. So it doesn't look really bright from that point of view either, as far as caregivers. As instructors, and I have a staff of 13, we're torn. We're not going to push someone through, because again, we always have in our mind that they're taking care of you, and you don't want someone taking care of you that was pushed through just to get through the program to be a nurse. I don't want that, and I know you don't want that. So I'm hoping that the numbers, I mean, it's a cycle. We're on the downward turn. And at IV, all you have to do at IVCC is walk down the hallway and look at the pictures. And in 2000, there's like 25 graduates. And then you keep walking down the hall, the pictures keep getting bigger and bigger and bigger. And we had 70-something, and at one point, since I've been there, and we're cycling back down again. And it's just a continuous ebb and flow, but I needed it to go the other way, quite honestly. We all do. We really do.
Thank you.
So challenges in healthcare, I would agree. I'm an operating room nurse. I'm the director of everything around surgery, pre, post, intra-op. And I can tell you that since my days in Catholic Nursing School in Chicago, Illinois, when the hospital schools of nursing were closed, we did a big disservice. It's great that we have our associate degree programs and our bachelor programs. However, we have a lot of the clinical areas that aren't covered because, as has been said, we're pushing through to the test and the academic part, which we all need and all of us had to do. But for me, nurses are retiring at huge rate. Baby boomer nurses like myself are retiring, and instructors. So nursing schools are suffering. Not only nursing schools, there are many of the medical professions that are suffering. The doctors, the professors that are in the academic centers are retiring, and it's very, very difficult to hire. We've interviewed, I believe, it took us, we're interviewing more now, but to get another trauma surgeon, we spent a year trying to get applicants. And now we do, because of people that have been a little bit further along in their career and want to make a change and come to another setting. But from the nursing standpoint, I now have had to offer to schools, we will train, if you have nurses that will commit to come to our hospital and can tell me why they want to work in an operating room setting, and will take 1 year off my books to train them, first in all the areas not in the operating room, so they learn how to assess patients and learn how to do the electronic charting and learn how to do the medications, et cetera, then I will do it. And that's what we had to do. I had to build a program where now I have 4 new grad nurses, which I never would have done at any other time in my career because it takes so long to train them. But they wrote papers on why they wanted to come. The instructor, who was one of our instructors at the hospital, who's affiliated with nursing programs, put it out there. There were 10 students who said, yeah, I want to be an operating room nurse. So they had to write a paper, and then he said, how many of you will commit to work at our hospital? 4 said yes. And when we interviewed them, I was thinking maybe 1 or 2, and they were all so passionate, and they all wanted it so much, and they all had had college, they had another career, so they weren't brand new, fresh 21-year-olds. They really felt that this is what they wanted. So they just finished their 1.5 months into it, and we're rotating them in sterile processing, where they have to clean the dirty instruments and learn really how to do. It's not all like the TV shows, and we tell them that. And sometimes people think, well, it's good money, and it is. It's a career you can have your whole life in different aspects of nursing. I worked here in LaSalle County for 11 years as one of the 2 school nurses for 31 schools, for our country schools and our parochial schools. And I did that while my son was in school, so I could not be on call and not, and be available for him. So you can do things like that in nursing at Forts in medical fields, but it's hard work. And the challenges that we all face now is that hospitals are graded. And so every hospital has, you're graded on, do you have surgical site infections? If you have a surgical site infection, you aren't paid. If it's Medicare, you do not get paid. So let's say you come in and have a total hip, and you come back within 30 days, actually it's a whole year now. If you come back within a year and have an infection, your next surgery is not paid for. I mean, the hospital doesn't, the patient doesn't have to pay, the insurance will pay, but you don't get paid, say if it's Medicare. So there are many things like that. If there are central line infections, we're graded on those things, and we should be. And so there's constant training, and to your point also, we had a chief medical officer who was, when we had our quality meetings each month, who said, yeah, we're good, we're below what our goal is, but it should be 0. We should have no central line infections. We should have no surgical site infections. We should have no returns to surgery for bleeding, unless we're talking about an accident or trauma. So there are many things that we have to watch everyone. No narcotics errors, no medication errors. There are look-alike, sound-alike drugs, so there are big signs everywhere. And still, since the universal protocol for timeout, and I don't know how many of you have heard that, but whenever there's a procedure, whether it's in the cath lab, or an operating room, or in an emergency room, the whole team has to do a timeout to say it's the correct patient, the correct procedure, the correct site, and this is worldwide. So WHO, the World Health Organization, all countries have this. The numbers have increased of wrong site surgeries. So we don't really know statistically, is that because more are being reported now? Or is it because you're zoned out? So it's something that's being looked at, there's research being done on it, and we hit it hard. We really hit it hard to where you have to do it. The people are reported if they are talking or the music is on during the timeout, because it has to be total silence, and the surgeon, the anesthesiologist, or the cardiologist, the nurse, the anesthetist, all have to agree. And those are things you don't see behind the scenes. They're a challenge because, again, you have to have people who care. You have to have people that know it's your mother, it's your father, it's your spouse, it's yourself on that table. And that's what we as health professionals try and impart. And in the meantime, we're fighting this economic battle and this battle with insurance companies and our politicians to make sure we have the best care possible, and it's a challenge.
Okay, so we've heard about challenges in the actual work environment and that. I'm going to talk more about the challenges I see my patients facing and that. So my job now, and just to kind of clarify, my actual employer who my paycheck comes from, I work for Sodexo, and we have the contract with President's Hospitals. So I actually go to Joliet area 3 days a week, and then down to Kankakee 2 days a week. And I strictly see outpatients. So I used to be at St. Mary's in Streator for 15 years and did inpatient and outpatient work there. But in my time at St. Mary's in Streator, I decided to become a certified diabetes educator. I found this is really my passion, helping people figure out how to manage this chronic disease. So even back when I was in Streator and trying to help, my fellow citizens down there, making better choices, lifestyle choices. It's, I'm like, why don't you come? Why don't you come to your appointment? Biggest thing, it's insurance. Lack of insurance. Now, public aid, we would get reimbursed even where I'm at today. We get, whatever we're going to get from our Medicaid, because since I work for a Catholic healthcare system, we don't turn anybody away. We're going to treat everybody and then, use the offset of our free care that we've provided in that. And so, it's there, but then I had people with insurance, and sometimes their policies would pay, sometimes they wouldn't. Then my Medicare patients, if you have a diagnosis of diabetes, or if you have renal disease but not on dialysis, your visit is covered. You get a certain amount of hours with a dietitian every year. So, and that is whatever Medicare, what we'd get reimbursed, that was kind of the going rate. So let's say Medicare was going to reimburse $150 an hour. That was my set rate. So that's what we charged everybody, $150, $150, $150. So the barrier to access becomes if you don't have insurance or your insurance doesn't pay for nutrition education, we call it medical nutritional therapy, the big fancy word for it, that's what you're going to pay out of pocket. And I see that as a huge barrier, even to the patients that I serve now. That it's like, even my Medicare patients, that maybe they don't have diabetes or they don't have renal disease. Maybe they're overweight. Maybe they have issues with cardiac issues and they need help with a low sodium or low fat diet. And as Daphne was talking about readmission rates, congestive heart failure, ding, 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 you can't come back in or you're not getting paid. And when I was at St. Mary's in Streator, we had a huge sodium reduction. And, really I would go in and see every patient that had a diagnosis of CHF and said, hey, this is what you need to do. This is what you need to look for. So that's when they were in-house. That's very expensive treatment when you're in-house. I mean, just to have a head in the bed there, it's $2,000 a day. So, I look at it, it's like, well, okay, or $150 to come see me when you're feeling better. That's where I kind of struggle and see a challenge that why don't we pay more for outpatient services and to keep people healthier and preventative medicine. And, that the biggest, the other big challenge, the big elephant room, where's that funding come from? And, that's, a great big issue. But that's what I see a lot of, where people like, I can't afford to come back. My insurance didn't pick it up. And, for some people, it's sad. And we talk about, when I sit down with the patient, it's like, okay, this is what doctor says you should take. Well, I had to stop taking my medication for 6 months because I couldn't afford them. And, or those test strips that you want me to test with, that meter that, someone else gave me for free. And I'm like, oh yeah, that's never a good deal for you. But, I work with my patients, what are your economic constraints? And you know what, maybe you don't need to check your blood sugar every day because those strips are expensive. And, from a big standpoint, I need people to spend money on decent food first and their medications. And I have very frank discussions with patients who are struggling about, what do they do? What should come first? And I'll be honest, I'm like, your blood, checking, you don't need to do that 4 times a day. You're not going to change the dose of the pill you're taking. And I have to explain and educate. And I think that's a thing too. There's a lot of education out there needed that would prevent people from maybe letting their health get so far out of control. And a lot of that comes with their own personal choices. But I think if that could be some incentive too, that, hey, you can come see the dietitian for maybe a half hour, we're going to run something, and you're going to get points. Maybe you'll get, points towards something else, attend this class, and, maybe that's a way to help get people engaged. There's got to be some investment, because then I have other people who know, hey, it's free, and they're showing up like clockwork, but they make no changes in their lifestyle behavior. And you know what? I kind of get those people off my schedule, because I'm like, you know what? You're not investing any time in this. I'm not going to fill a slot for a follow-up when I know I've got someone over here, maybe a brand new type 1 kid that I need to get into my schedule, but I've got you coming in because someone else is going to foot the bill for it. So I've gotten a little savvier as time goes by. It's like, if you're not putting forth the effort, you may not get as many follow-ups. If they really need it, they do, but there's some people, it's just like, I'll have coffee with you out, after hours or something. If you need a friend, we'll have to figure out something else for that. But I think that's the challenge, though, is, helping people live within it. And then, one of my friends, we were coming back from something, and, she told me, she goes, my son and I don't have health insurance, Ann. I'm like, wow. And I know she works full-time, and she goes, I can't afford that. She goes, it would cost, because I think she works for a smaller company. She goes, $600 a month, or she rattled off the fee, and I got to doing the math, and I'm like, well, yeah, I guess that is true, and and it's like, and I thought, well, okay, what's the penalty? Well, the tax penalty really isn't that bad, so I see why people roll the dice, but I thought, my goodness, what happens when you do get sick or something terrible happens? And that's where I think we need to look out for, maybe a kind of a two-tiered plan, that we've got some basic preventative, inexpensive, well visits, and then something for catastrophic care, so when that awful thing happens, we're covered there.
Thank you. Thank you very much. Our last segment is, what do we have to look forward to coming up the road? It's a wide open field. And I have to say, thank you all so much. This is extremely informative.
Glad to hear that.
Go for it.
I wish I had more encouraging words to say than I do. So, possibilities in the future. A bigger role of technology. And as we've said earlier, technology has helped us to decrease errors in care through our medication paths and scanning and that type of thing. We have patients tell us that they feel like they're in Walmart. That's kind of the same noise it makes when they scan the stuff at Walmart. So I think there's going to be an increased role for telemed, more probably than I can envision. However, it's kind of happening, not live right now. I'm a new grandma. And our first grandchild, she's 5 months old now. But my daughter-in-law will take a picture of whatever. Her thumb was all inflamed, so she took a picture and texted it to the doctor. And the doctor said, I want to see her. We didn't used to do that. Wow. I mean, the doctor can look at the picture and say, get her in. I mean, what a way to do triage. I want to see you, I can see tomorrow, you, I can see in a couple days, based upon actually being able to see what they're talking about. There's definitely potential there. And I definitely think what Ann said, the focus has got to shift from care, providing care, which still needs to be done, and needs to be done well, to health promotion versus caring for someone with a disease. We want to prevent that from happening in the first place, because we would have a healthier country, as everybody would benefit from that, with a focus on health promotion. I say that, but they taught me that 36 years ago when I was in Catholic school, nursing school, that we were going to see a shift from the, working with the disease process to health promotion. I'm going to be done, and we're still going to be saying the same thing. And that's sad. That's really sad. There has not been that much of a move. I definitely think there's going to be an increased role of nurse practitioners and physician's assistants in healthcare, because there just aren't enough doctors to go around, and sometimes that's good. In some cases, with my dad, for example, he sees a gastroenterologist, and I think I've truly seen the doctor once, and all the other times have been either a physician's assistant or nurse practitioner, all of our contact. So they always say, well, you need to come in and see the doctor, but we really don't see the doctor. So I think there's a downside to that as well. When I want to see the doctor, that's what I mean. I don't want to see anybody else. When I want to see the nurse practitioner, that's what I say. That's the one I want. So, and a lot of that is education as well. A lot of people will call a physician's assistant, they'll say doctor. They're not a doctor. They're a physician's assistant, and there's a difference. About a month and a half ago, my dad fell and was in the hospital for 5 days. And quite honestly, I have said to many of my acquaintances, I don't know how families do it that don't have a nurse in the family. Because my role was very important for communication, because he didn't understand some of the things they were saying. Repetition would have occurred. Well, we're going to get this test. I'm like, you already did. My brothers wouldn't be able to pick that out. We had to go down to Bloomington to a specialist, and he said, I want to get this test. It was dye for his carotids. And I said, he had a CAT scan in Ottawa, and they asked for an extra film, because the ultrasound wasn't very good. And he was real down. And I said, they asked for an extra film. And he said to me, why wasn't I informed of this? I'm like, I'm just the daughter, really. Yeah, I got RN behind my name, but my brothers wouldn't have known, and to put it together like that. So, but it was all the same hospital system. So he walks to the computer and click, 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 and he said, come here. I said, what? He said, come here, I'm going to show it to you. It's wonderful pictures. They did a great job. And he was all smiles, because he said, this is much better than what the ultrasound showed. So he needs to take an aspirin a day, and I'll see you in a year. I mean, he completely changed his tune. But if I hadn't been there, he would have reordered the same sum test with dye, which isn't a bad thing, repetition, but I mean, I was able to prevent it. And every family needs an advocate that knows what's going on in the inside of the healthcare world, and not everybody has that. And that's why the nurses have to be the advocates for their patients too, because the average person just doesn't understand the technicalities of it.
So where will we be in the future? Well, I think in some places, especially out in the West, they are using telemed, where there's so many miles in between out in Montana and Wyoming and all the Dakotas, the western states, there just aren't specialists. And so there are doctors that are using that. I think that is definitely a wave of the future. And as we talked about the electronic medical record that you mentioned earlier, that was one of the first things that was thought. The goal is that eventually John goes in to see Mark McVeigh, our doctor here, and Mark needs to send something to a specialist in Chicago or call him. He'll be able to pull up his chart and look at it. The unfortunate thing is that we have so many different electronic medical records, and many of them do not talk to each other. They don't interface, and that's also a huge moneymaker, millions and millions of dollars per each system. So I see that as a positive, but at some point there has to be a way that they all can be connected and interface with each other, because they don't right now. So some are a little bit more interactive than others and have more of that capacity. So definitely the electronic medical record, the sharing of information, so that if you're on a trip and you're out in California or you're in Florida, the doctor you go to there in the emergency room should be able to pull up your record. So I see that as something in the future. In the surgical realm, there are pros and cons to robotics, but one of the things that does happen, especially from the teaching standpoint, is that a surgeon at the University of Chicago can send what he's doing robotically to Japan or to a classroom anywhere really around the world. And there even are some that are doing procedures robotically where the surgeon is elsewhere, not in the room. And here, most robotic surgeries occur where the doctor is actually in the room, but there's a teaching module as well, and there is an assistant at the field. So there's no robot like R2-D2 or C-3PO walking around. There actually are doctors at the field, but there's a doctor at the robot, and they actually are controlling the instruments that are in the patient. And the positive of that is that any human shakes, and no matter how good the doctor, their hands are going to shake. When they're using the robot, that is taken away, and that little problem goes away. And there are specific surgeries that's good for. I do also see the future, as we talked about in the last segment, as a challenge that we really need people in the healthcare professions. We need nurses, we need doctors, we need radiology technicians. That's a hugely specialized field right now because there's so much done in nuclear medicine, radiology, interventional radiology, that you don't have to have huge procedures. There are now heart surgeries that are being done with scopes that they don't have to open the chest. So there's much technology that's here now, that's being developed in the wave of the future. And to go to Ann's point, we really have to get away from the heads in beds concept that has been around for 75 years. And we're doing more and more and more outpatient, and yet the hospitals are still looking at getting reimbursed more for inpatients. Of course, the days that you're there, the length of stay, after a certain number of days, you're not paid. But we need to look more at reimbursement for outpatient, and there's more and more outpatient things being done, whether it's prevention like Ann is doing, and working on teaching, on helping people that it's not necessarily treating a disease. That's the other piece. We need to really exponentially increase health education and teach people the correct diets, and we all need to have a role in what's healthy and what isn't, and the chemicals that are in our food and the genetically modified food that we're eating. We really need to be educating people on that to help prevent disease.
Okay then. So the future. I saw the future today. I got to interact with the future today. I got up at 3:30 this morning, was in my car by 4:30, and because I work with Sodexo, I'm part of a diversity holistic health campaign that we have, and so I was at Fenger High School on the south side of Chicago, and it's kind of stuck between where the Dan Ryan and I think the Skyway goes off. So it's kind of there in that upside down U in the Roselawn neighborhood. And we did a health presentation, and chefs from all over the country fly in. There's another local chef who comes from the suburbs, but from different lines of Sodexo's business. So what we do, we make healthy items and we're high school students, and there was, our young youth and kids that, have a different lifestyle than many of our kids probably live here in LaSalle County. But they were great kids. They listened. They had wonderful questions. But, was getting, the message out, hey, you can make healthy things. You can make different choices for yourself. Because we talked about preventing, illness prevention and that. And, giving them opportunities to start making better health choices, because that's the one thing, you start early making better choices, you're always going to have pretty decent health. And that's where, we really need to focus on. And, Daphne alluded to, I always look at, what drives up this health care? And, in the back of my mind, I'm like, well, we have the cost of the pharmaceuticals. And then we have the food. And, in my profession, dietetics and food science and that, it is big food and big pharma that, people are worried about this, that, and the other. And every day, every meal, we make a choice about what we're going to eat. So, we need to start really thinking about it too. And it's not an overnight process, baby steps to better health. But, start, for your own personal health. Take care of yourself. And then maybe you won't need, expensive medical care. But every day, every meal, you make a choice. And, I say that because I have patients coming in, well, aren't you going to give me that pill for weight loss? I'm like, no, I can't prescribe that for you. Diet and exercise, better food choices, get, moving, walking. And, they look at me like I'm crazy. I'm like, but that is the foundation of it. And, I'm like, those pills only work for as long as you take them. And if you've not made some behavior changes, once you stop taking the pills, that weight's coming back. That's the sad story of it. Or other people, well, I'll give myself extra units of insulin if I'm eating a big candy bar. Or they're on, I don't have high blood pressure, I take pills for that. I'm like, well, the thing of it is, that's why you don't have high blood pressure. This is how my work day goes. It was great working with those high school kids today. I didn't hear such crazy stories like that of, like bad judgment. So, but that, it is getting out and, getting the message out. And now with the electronic age, I battle that too with my patient. I read this on the internet. I read that on the internet. I'm like, well, yes, there's all sorts of things out there. But then we have to always look at, bring it all in and what's going to be the best and putting the filter on it. And I think that's a lot of things that go on day to day in our, everyday life. There's a lot of noise out there. And we have to filter out what's going to be best for us and, what keeps us focused. And because stress is a huge impact on our health, a little stress management too. So sometimes we need to turn off stuff to improve our health too. So that's all I have to say. Neil, you can wrap it up.
Thanks. So I'll say a couple of things about the human element of healthcare, since that was a sort of a common thread through the last couple of remarks. So it's hard to find good people. It really is, and that's true at the physician level, it's true at the nursing level, it's true at the technician level. I mentioned at the outset my mom's battled with Crohn's disease, and that same episode I described earlier with her in the hospital and me trying to make the soccer team. After that happened, my brother asked her at some point, so Mom, what's the biggest thing that makes a difference when you're in the hospital? And it's not surprising to these folks. She said, it's the nurses. It's not the physicians, and so that's why he ended up going to nursing school, and that's why he ended up now as a CRNA, a nurse anesthetist at the Mayo Clinic. His healthcare all over the place, right? His wife, palliative care, gerontology nurse. I mean, these are people, very, very hard things. I ended up in healthcare for the same reason, but I can't stand the sight of blood, so I'm an administrator. I don't have to get my hands dirty. They're better people than me, and certainly in that respect. And it's hard to find people. It really is. Good nurses are worth their weight in gold and then some. Bad nurses are absolutely terrifying, but good nurses are extremely hard to find and extremely important. There's a lot we can still do And I talk about hospitals a lot because that's how I used to work for. Those were my clients. Same is true in other sites of care. But there's a lot we can still do at hospitals to improve the quality of care. You'd be surprised the number of hospitals, surprised and horrified, surprised the number of hospitals I've still walked into within the last couple of years that were able to substantially reduce infection rates by doing hand washing campaigns. You'd be surprised the number of hospitals that improve patient outcomes, reduce readmission rates by taking an extra 10 minutes to explain to patients who are leaving the hospital how to take their meds. There are hospitals in this country that have driven the readmission rate, important for the patient, increasingly important for the hospital for the financial reasons we described earlier, 25, 30, 35% just by staffing a pharmacist to explain, this is why you're taking this med. It's been sent to your pharmacy. You really need to go pick it up, and here's why. There's cases like that all over the place, and it makes a serious difference to the quality of care that people receive. In a systemic sense, though, I want to go back to something that Daphne said in her first answer. We talked about, from a couple of different angles, the history of American healthcare, where it came from, and why do we have the screwy system. There was this moment in history where a lot of countries, they looked around, and it's no coincidence that most of the countries that have universal health care built that system in the mid or late 1950s. Because what happened was that countries, particularly in Western Europe, they looked around and they realized they had just spent hundreds of millions of dollars to kill tens of millions of people. And they asked themselves a pretty simple question: can't we do better? Isn't there some other better outlet for our energy and our time and our money? And they made the decision they weren't going to go down that route again. We're not going to spend 16, 17, 20% of our annual government budget on military and weapons. We're going to spend it on healthcare. We're going to spend it on making an appreciable difference in people's lives. And thankfully, we don't find ourselves in quite that kind of a moment of history, but we're starting to get pretty close. I think we're at a moment in this country, thanks in large measure, thanks mostly actually to folks like you, come out to be the audience for groups like this, for conversations like this, where we realize we can do better. It doesn't have to be this way. That's an important message to take with you. It does not have to be this way. There are dozens of better ways to do healthcare than the way we do it in this country, and all of them are better. They just are. And so we're at this moment where I think we can make the decision to finally get off this track we've been on. It's not a nonpartisan event, but I'll say, as a Democratic candidate, I support the Affordable Care Act. The Affordable Care Act really is the best case scenario. The Affordable Care Act is as far as we can take the model we have in this country. If you insist on having private insurance companies, private for-profit insurance companies, because there are countries that do it just fine with private not-for-profit insurance companies. If you want to have private for-profit insurance companies, this is it. This is the best case scenario. Putting Band-Aids over bullet holes, throwing hundreds of millions of dollars in extra subsidies to insurance companies whenever they cry uncle. I'm on tape, so I'll make sure I put this in context. I don't often agree with President Trump, but he's right about one thing. The CSRs, the cost-sharing subsidies that just make it, they were shut down last week by his executive order and potentially now brought back in thanks to a Senate bill that was just released today. That is a bailout. That is dumping good money after bad into a system that doesn't make any sense. So we need to do better, and we need to get off this track, and it's not going to be easy. It is going to be a challenge. There are huge entrenched interests to fight back against, to overcome, to deal with the hundreds of millions of dollars of lobbying the private insurance industry does every year. And quick, one footnote. Go back to 2008, 2009, go to 2010. Go back to look at all the senators, and this is true on the Democratic side as well. Go back and look at all the senators who were instrumental in setting up an Affordable Care Act, a huge health care reform bill that nonetheless managed to funnel more money to private insurance companies. And ask yourselves who wrote that bill. Tom Daschle, Kent Conrad, Byron Dorgan. These are names out of a hat. It's inside baseball. senators from small states that are easy to lobby, that have cheap media markets, that are a real cheap date, pardon the term, and got money hand over fist from the insurance companies. That's why we're still where we are. So there's a lot of work to be done. But I think now that people are waking up, now that we realize that we can do better, that we deserve better, quite frankly, I think we can get off this track, and I think we can get to a truly universal system. And that may look like Medicare for all, it may look like something else. But the important thing to keep in mind is the objective we need, where we want to go. We can pay a lot less, get a lot more, not let your boss have a veto over what doctor you go to, not say just because you happen to be a woman and you happen to work for Hobby Lobby, that therefore that doesn't mean you get certain health care services. We can get past all of that if we build a large enough coalition. And I'm looking forward to you all being part of that. So thank you again for coming. I'm sure we all look forward to your questions.
Thank you. Wow.
Yeah, you guys rock.
An amazing breadth to your answers, and such a great focus on the quality and also the economic common sense in moving towards the future. Do we have questions?
Well, you can bet I do.
Please.
A couple of them. Julie, I think it was you talking about your father went to another doctor. Wasn't that the doctor's responsibility to read the file before he saw your father? Sorry for the bad tone.
He was able to pull it up right away, so.
Yes. He's paid a lot of money to treat patients. You come down there he knows from out of town, and he doesn't take the time to have him or another officer to read the charts. If you weren't there, you had to. That's not, I don't blame that on the healthcare industry. I blame that on the individual. So we can't talk about it.
Yeah,
Correct,
I
right?
was talking about it from a protecting my dad point of view.
Absolutely.
That I was glad to be there to help him. But
Well, you
yes,
helped the
my
insurance company because they didn't have to perform the test and pay for it again.
You should have gotten a percentage.
my expectation though was exactly what you said, was that he would be familiar with the record before we entered the room.
I think the education part needs to come into not having a fear of the physician, because the physicians treat themselves like God. Sorry, maybe not. We have any doctors here? Treats themselves like God. I think they need as much education in how to treat patients as patients need education on how to deal with doctors. And I think that's what it is. And I'm on my soapbox.
Can I just speak to that? Because,
Please.
So I will say things have changed greatly from the Catholic nursing school days decades ago. The head physicians now have empowered. I've had them come talk to my nurses that if there are issues, they want to hear about them. And the nurses now are empowered to, if a physician is not doing what's right, so the advocate, we use that word a lot, you have to be the patient's advocate. If there is something wrong, got to report it. And so now there are more reporting mechanisms, even anonymous, although I will say that most of the people will put it in because there has been a good response from the administrative, like chief medical officer, the chief of surgery, chief of medicine, where they want to know. And patient complaints are another health grade, of course. So when a patient complains, and we have to handle it, in my role, it immediately will be, we have 24 hours to answer a patient complaint that comes in. If we're not dealing with it right away, or maybe a phone call in. And I think that's a huge sea change where that just wasn't there before. So now, you're right, it was professionals treated like they were on a different level, and that is changing. Maybe not quickly enough, and it depends on your institution, but it is happening.
Thank you.
And I'll say something about that too.
So over at St. Joe's, I teach a diabetes group education class, and it's self-management. And I tell the patients from the beginning, the attendees to the class, I go, you're going to learn how to better manage your disease. and be able to ask your doctor the right questions and ask for these things. And even on one-on-one visits, I'm giving people a pamphlet. These are things you want to ask in the doctor's office and stuff. And many times I have to go over people's medications because when they're supposed to take them, not take them, and good things like that. But there is a huge disconnect. And being as an outpatient, I might just get a slip of paper from your doctor saying, hey, see this patient, they have diabetes, no other information. It's very frustrating. But the electronic medical records, we use one system in the hospital, but then our medical group doctors are on a different thing. But I can, if they're a patient coming for that, I can log into their record and print that off and have half a leg to stand on. So I think technology is improving it, but I, help empower my patients to be a better patient and not to be, bamboozled. I'm like, you can ask your doctor a question. There's nothing wrong with that.
But shouldn't that start at education in grade school? How do people don't know how to talk to their doctors? At the same time, they're given school lunches that are branded, goldfish in a bag, Pillsbury. They can count their calories, they can use their food pyramid, and they can still give your kid an unhealthy lunch because it's subsidized by a place like ConAgra. So how do you fill that gap? How do you fill the gap between education and healthcare for basic people like us? Because you got a huge one, huge gap there.
Well, how you would work that into the school curriculum, but they do talk about health and stuff. I mean, that's part of the health curriculum. But you bring up the good point too, that the shameless marketing that's done to our students, and the school lunch programs with things being branded and all the subsidies, and that's all it is. And I'm always people, this healthcare, oh, the government's paying for, that and the other. I'm like, the government's paying for a lot of stuff. Wake up, that's the biggest thing. Get educated, get educated, get educated. When we first met as the Indivisible group, I said, start reading, start getting better informed, because you know what? I think we all kind of sat around and said, life is good. It's good. I don't need to pay attention. And now we're paying for it. And it's the hardest thing. But empowering, and the internet is good, bad, and evil, but, and that's the thing too, though. It's this food this week is the superfood that's going to cure everything. My goodness, if that was the case, I'd be out of a job tomorrow. But that's, I think they are teaching the kids how to maybe be a little more savvy connoisseurs of the internet in school.
So I want to touch on one thing you mentioned at the beginning of that question before getting into the diet-specific stuff. And I'm still learning how to be a politician, so I'm trying to do a better job of hearing a question that's like tangentially related to something I didn't get to say earlier, but I really wanted to say, and answering that question instead. This is going to sound silly. This is going to sound really silly, but it's true. The reason why the consumer model we have in this country of healthcare doesn't make sense is because you have to make those decisions when you're sick. And that's a duh. I mean, I don't want to sound like I'm oversimplifying. I don't want to sound like I'm being condescending, but it's worth keeping in mind that it's hard to ask your doctor these things. It's hard to, sort of take command, make that, I think Anne used this metaphor early on, think about it like you're buying a car or buying a phone or buying a sweater. We put people in this position where they have to make this super complicated, super sophisticated decision about their care, where to go, who to see, what to pay for, what's worth it, what's not worth it. You probably didn't have the training, unless you're one of these folks up here, to make that decision in the first place. You certainly don't when you're sick. If you happen to be seen at sort of a Cadillac hospital, like University of North Carolina or wherever, best case scenario is that you have someone in a call center arguing with the insurance company on your behalf to cover the chemo or the infusion or the whatever, something really expensive, a procedure or a drug. That's hardly any better at all. Our SOP, our standing operating procedures, to put people in this position, that really is just by definition impossible. It's a big reason why things don't work the way they're supposed to.
So I'm picturing and you guys have just illuminated so many things in my head. I'm like on fire. But here's my picture in my mind right now. system is a kind of a corral that we're all inside. And there are all these different support posts all the way around the corral. And the support posts are education, they're insurance companies, they're food companies, they're marketers. They're all these different supports that are combining to hold up this corral and keep us inside of it. What I want to know is, where do I swing the axe to get the most bang for my buck?
To get out.
Yes, to get out.
O-U-T.
Yeah, I want to see this thing, I want to see this change. I want to see an open door in that corral so that we can get some better systems, and I don't know where to start because it's so big.
Yeah, I pass this off to the other folks. I mean, I would just stick with the private insurance companies. There are plenty of problems with hospitals. There are plenty of problems with doctors. To Steve's comment a second ago, it's not as though anyone's hands are entirely clean in this. But what I always come back to, both in talking to people as part of the campaign, but also my previous professional life, is how little insurance companies actually do, how little value they put on the table, how little value they add to any of this. And again, I've worked with some hospitals that frankly don't work that well. I've worked with hospitals that have a problem finding qualified nurses or qualified physicians. I was at a hospital, one place once, very small town, very much in the middle of nowhere, 2 hours in the next city of any size. Sat down with this administrator, started interviewing her. I'd never met the person before. And 30 minutes into this conversation, I asked her a question about, trying to keep the technical stuff out of it, a question about the respiratory docs. So if you're a physician, if you're working especially in an acute area like respiratory or cardiovascular, there's something called an order set. There's like a list of things in the system that say first you try this, then you try this, then you try this. And their pulmonary physicians, the respiratory docs, weren't following the directions. Really simple stuff. It's important to follow the directions for all the reasons you were describing earlier, because it reduces error. And they wouldn't do it. And this administrator, she I think was the CNO of the hospital, just sort of breaks down in tears because they couldn't get them to follow the order sets because they couldn't recruit better people. They were stuck with who they were stuck with. So there's plenty of that stuff out there, and I don't want to be glib and say it's just the insurance company's fault. But at least the physicians do, they're contributing at the same time. Even bad physicians are doing something of value. Even bad nurses or NPs or PAs or whoever are doing something of value. Because private insurance companies really, as far as I have ever been able to see, unless you all tell me differently, don't contribute anything. So that's why I would start swinging the axe. And somebody mentioned this before. That's why we need to go to Medicare for All or a system like it.
What happens to all those jobs? Because that's, in the insurance industry, that's a big part of the economy. So I'm with you, but I want to know if there's ramifications, right?
So they'll go elsewhere. I think the answer I have to your question is what's happening in this room tonight. And there's some of us here, Katie sitting back there, that have been involved in a lot of local environmental issues for many, many decades. And you have to own it at the local level. And you have to push it, and local meaning our community, our county, our, looking at our elected officials to start pushing it. We have to say what we want. And the change, it's pretty simple. We shouldn't still be talking about Harry Truman from 1945. We shouldn't. I mean, it's embarrassing that we're here. We have to take ownership and let the people that we elect to office say we need to work for a national system, healthcare for all. Again, as you said, whether it's Medicare for all, whatever the system, it has to be equal. There are going to be jobs for people. The insurance industry, I mean, as far as I'm concerned, that's not my issue. Those people will go, if we have national health care, there are plenty of jobs for people that, in the structure of running it, it's just like Medicare. There are people that have to work. You put them in, it's just like saying, do we keep the coal mines and we keep coal miners instead of investing in the wind industry? And now China has just gone off the charts in really trying to get themselves off fossil fuel, and we're left in the dust. It's growing. So we have to own it. We have to say what we want. And I personally will also say the environment has a huge effect on health. And there are more and more and more studies being done. There were not a lot of cancers around when Judy and I started out in nursing. There weren't.
Autism.
And autism, all kinds of things that have happened. And we have to look at the chemicals, at the genetically modified organisms. There was gluten allergy. I never heard of a gluten allergy 40 years ago. And we have totally destroyed the wheat. We now have, if you look at pictures of wheat, and I know we have farmers in the audience here of years ago, it was amber waves of grain, high, tall. Now we have stunted wheat that has been modified over and over and over again to produce more and more and more. And whether it's bigger strawberries in California, what we put in our bodies, to Ann's point, what we put in our bodies is what we are. And if we don't insist, now why is there more and more quote organic food? Most of us grew up in this area, had huge gardens. We never put chemicals on our gardens, right? You put marigolds in, you had the insects, that ladybugs, whatever. Organic, now we're seeing more and more of it because people, the consumer is requiring it. And so that's where it belongs with each one of us, insisting that, yes, we go to the school board and say, what are you doing? Do we really want this food here with the garbage that you're feeding our children? But we have to go back and remember when Ronald Reagan called ketchup a vegetable.
Sorry. One of the, sorry, go ahead.
I want to say too that the mindset in the healthcare community is changing. It's slow, but it is changing. So a lot of physicians now, so when I first entered nursing, every physician was considered basically an independent contractor. They would contract with the hospital to have privileges. And so there was no connect between the staff in the hospital and the physician. And so there was no check or balance. Well, now more and more physicians can't afford to go into private practice. And so they're hired by the hospitals and the organizations like OSF, which puts the physician on the same playing field as the nurse. Well, so nurses are now feeling more empowered if they have a doctor who starts having a fit and yelling and screaming like, wait a minute, we're both employed by the same people. And I don't have to put up with that. I made that decision a long time. I don't know about you, but you kind of outgrow it. You know, when you're new, you just stand there and take it. And then there's just a point where I thought, you know what? I paid my dues, but the newer nurses are reaching that point sooner than we did. A lot of people don't think they can ask. My dad's a good example. Well, ask the doctor. Well, I can't do that. He's the professional. He's the expert. He's got to know what he's doing, and they trust that and won't question. And again, it's educating people and letting them know, you know what, you do have the right to ask questions and ask your doctor. You don't have to just ask the nurse to ask the doctor. You can talk to the doctor, and your expectation should be that you get a straight answer that you can understand.
I would like to stay here for another half an hour, but I think in fairness to those people that we promised they could get home by at least midway through the Cubs game, we need to call it. If you wouldn't mind mingling for a few minutes in case some people have additional questions. But on behalf of Ottawa Indivisible, I would like to give you our deepest thanks for coming out tonight, for sharing your insight, and for answering our questions.